Hello, everybody. I'm Anthony Gonzalez, and I'm the program coordinator with the Higher Education Center for Alcohol and Drug Misuse Prevention and Recovery. I want to welcome you all today to our webinar titled What You Need and Want to Know About Harm Reduction, a panel discussion featuring our moderator, Ahmed Hosni, and our panelists, Corey Davis, Chase Holleman, and Susie Mullens. Before I get started, I do just have a couple of housekeeping slides I would like to review. Here on the screen should look somewhat familiar as we are in the Zoom webinar format. We do welcome your questions for our panelists today. Please feel free to submit them at any time through the Q&A feature. We do have the chat enabled, so please feel free to share who you are and where you're joining us from. But please use the chat to share reflections and resources. But any specific questions that you may have for our presenters, please put them in the Q&A. We do have captioning available today, and that can be turned on through the bottom dashboard. If you have any trouble getting that set up, please reach out to me in the chat, and I can help you get that set up. We encourage everybody to learn more about becoming a member of the Higher Education Center. You can learn more about the different membership tiers and the benefits that go along with them by visiting our website at hecaod.osu.edu. We also have a few upcoming events that I would like everybody to be aware of. We have a water cooler chat happening next month on September 13th and is titled Return of the Students, Time to Stop, Collaborate, and Listen, and it will be moderated by Doug Everhart. Additionally, we have a free webinar happening at the end of September on the 29th and is featuring Ahmed and Mackenzie Hogan and is titled Finding Common Ground, the Intersection of Student Development Theory and Recovery Support. And with that, it is my great pleasure to turn it over to our moderator today, Ahmed Hosni.
Yeah, thank you so much, Anthony, and hello, everyone. Thank you all for being here for this really important and timely discussion. My name is Ahmed Hosni. I use he, him pronouns. I am the Director of Recovery here at the Higher Education Center. I also work at Ohio State in our Student Wellness Center, where I support our alcohol and other drug initiatives across the continuum. And I'm really excited to be here for this conversation. College campuses have long been a place where substance misuse and drug experimentation has been baked into the culture and expectations of the student experience. Most of society knows it, expects it, tolerates it, and in many cases enables it. But it's also important to note that college campuses are also a place where harm reduction has been practiced for decades, specifically regarding alcohol. Yet, when it comes to other forms of harm reduction that are proven to prevent deaths and increase access to healthcare and services, many campuses continue to drag their feet or outright deny the need for these types of services. Today, we're going to talk with individuals who are working to increase access to harm reduction services for drug users, especially those on college campuses, and to learn more about how we continue pushing this conversation further. And so I am happy and to be moderating this conversation and to introduce my or allow my panelists to introduce themselves. And so first I will start with Corey Davis. Corey, if you'd like to go ahead and introduce yourself.
Yeah, hi, thanks for having me. Corey Davis. I am a public health lawyer. I run something called the Harm Reduction Legal Project at the Network for Public Health Law, which is a nonpartisan nonprofit organization. And I'm also deputy director of the Southeastern region at the Network for Public Health Law.
Awesome. Thanks, Corey. Thank you for taking the time to be here. And Chase Holleman.
Hey, everyone. Thanks for having me here. My name is Chase Holleman. I'm a public health advisor at SAMHSA, and I'm the harm reduction lead within our Office of Prevention Innovation, which lives in the Center for Prevention. Glad to be here.
Yeah, glad to have you, Chase. Thank you for taking the time. And of course, Susie Mullens.
Thanks, Ahmed, and thanks for inviting me to be part of this panel. I'm Susie Mullens. I'm the program coordinator for the West Virginia Collegiate Recovery Network.
Awesome. And so, Susie, I'm going to stick with you for the first question, and ask that you, if you would, just share a little bit about your current role and how you began working around harm reduction.
So my current role with the program director for the Collegiate Recovery Network here in West Virginia, and we are funded through state opioid response funds. We work with 8 out of the 11 schools that are part of the Alliance for the Economic Development of Southern West Virginia. So these schools came together to help stimulate the economy and work together collaboratively. And the president signed on to have the application for these services to be on campus. So we have 8 peer support specialists that work on 8 of the 11 campuses. And for me, getting involved in harm reduction really started back in 2014, 2015, when we passed the Good Samaritan law and allowed for more access to naloxone. I was working at WVU, West Virginia University. I saw somebody in the chat post that they were from WVU, and we started the first collegiate recovery program in West Virginia there in 2015. So part of what we did then, it was when the first large purchases of naloxone happened. And so we were very involved in putting those together and starting to get word out on campus. And then from a personal perspective, my great nephew passed from an overdose in the parking garage in 2017. And, so that's from the personal standpoint.
Thank you so much, Susie. And Chase, same question to you. Can you share a little bit about your current role with SAMHSA and how you began working in harm reduction?
Sure. So my current role within SAMHSA is basically I spend a lot of time engaging stakeholders. And most of my time has been spent building a framework, including a definition for SAMHSA. We know harm reduction has a definition already. SAMHSA needs its own, as well as best practices and principles. We've been working hard on a framework that will guide SAMHSA and our national partners' work moving forward. And how I got into harm reduction, thinking about it, I guess I got into it before I knew what it was. When I would go to websites like Arrowwood, and me and my buddies would carry strips of buprenorphine in our wallet in case one of us went out, so we could bring each other back. And as a disclaimer, there is no evidence that works to reverse overdose. It is what we did. But in a more formal role, I was privileged enough with melanin deficiency to navigate my way through the carceral system and go back to school and to social work. And just got involved there, learned a lot from people who've been doing this a long time. Started with naloxone distribution and syringe services in North Carolina, eventually founding and directing a program that doubled as a clinical training site for social work students, getting their bachelor's and master's, where they would be able to provide services underneath my supervision.
Thank you so much. And then Corey, if you could share a little bit about your role and the work that you do around harm reduction as well.
Yeah, sure. So, at the Network for Public Health Law, we are, really a resource to folks who are working in harm reduction, very broadly defined, right? So everything from people who are, giving out needles from the trunk of their car to the executive office of the president, So, and we do that both proactively, creating fact sheets and doing webinars and stuff to kind of get information out, as well as responsive. People can actually, I was going to say call us up, not too many call these days, but email or DM us, and we, we'll try to help people out. I didn't know about harm reduction until I was in law school. Which is a little bit ago now. I volunteered for what we used to call a needle exchange, we now call a syringe services program, in Philly, and I was lucky enough to be able to get some funding to work at that needle exchange after I graduated, running basically like a civil legal aid clinic out of the needle exchange. And then I went to I actually got a MPH degree in North Carolina. So there's a strong North Carolina connection here. And while I was there, I got involved. There's a group called the North Carolina Harm Reduction Coalition. So I started out kind of just volunteering with them and ended up on the board there. And yeah, have been working at the Network for Public Health Law for about a decade and kind of slowly, integrating harm reduction into our work so that I'm now able to do that full time.
Yeah. Thank you so much. And so, yeah, first, before I jump into the next question, I just want to point out to the audience that we have a tremendously talented and experienced panel of individuals working in harm reduction at the local, state, national, and campus levels. And so please, please, please utilize the question and answer function in the Zoom room and ask your questions. And we are excited to hear what questions you have and to pose them to our panelists today. And so one question that I do have prepared, though, is I'm going to start with you, Corey, is how have local, state, and national policy and law evolved to support harm reduction across the country? And how much further do we need it to go?
How long do we have? I mean, it's a really broad question, right? I mean, I think that the ways that it has changed are pretty, probably obvious to most of the folks at this meeting, right? I mean, these are things like, state laws that make it easier for people to get, naloxone, state Good Samaritan laws, which, to some extent encourage people to, to call 911 or, for in this context, hopefully, campus security or, your RA, whoever it might be that can get you help. At the federal level, to its credit, the previous administration and this administration as well have removed some barriers to medications for opioid use disorder, medications, buprenorphine and methadone. We've seen some states acting to do things like remove some barriers to syringe access, remove some barriers to fentanyl test strip distribution, and so on. So there are a lot of positive changes at the federal, state, and to some extent the local levels. I mean, from my standpoint, I think that the big problem is that all of these are kind of still swimming against the current, right? That the policy, the overarching policy is, something like people who use the wrong drugs are bad and we should make life hard for them, right? Drug use is criminalized at nearly every state, and at the federal level, paraphernalia is criminalized in nearly every state, and at the federal level. And these changes, that the states have been doing mostly, are just little carve-outs from that. Fentanyl test strips are like, well, yeah, okay, you can give out fentanyl test strips, but not, if we have a strip that's going to test for, benzodiazepines. We'll still arrest you, throw you in jail for that, because we actually don't want you to be doing drugs. We just have this tiny little carve out. And syringe exchanges work the same way. You get the same exact syringe, from Amazon delivered to your dorm. Maybe you go to jail. Whereas if you're able to go to a needle exchange and get that, well, you're kind of okay. It's still just sort of, we still have a long way to go, in my view, is sort of changing that big narrative, to saying like, look, we actually believe that substance use disorder, to use NIDA's terms, right, is a chronic relapsing disease of the brain, right? It's not a moral failing. It's not something we should throw people in jail for, any more than we should throw people in jail who are overweight, who are having heart attacks that were preventable if people would just eat better and exercise and so on. We don't throw people in jail for that. But we still have this idea that, if you are, making bad choices around, drugs, we're going to throw you in jail. That is the baseline for the federal government, for the state governments, and for the local governments. And so from a policy standpoint, I think that is the big thing that we really need to keep working on, is changing, harm reduction from this sort of carve out from the umbrella, which is still, these are bad people doing bad things and they need to stop, to being this more, reality-based approach that recognizes like people are really complicated. People use all kinds of drugs for all kinds of reasons, and there are ways to, push people in the direction of being healthier, without stigmatizing, without resorting to the criminal justice system. So that's my, it's my big picture thoughts on it.
No, thank you. That was great. And Chase, what are your thoughts on laws and policies and maybe a direction that we might see them go in order to increase access to services?
It's hard to follow Corey on this.
Right.
Speaking for SAMHSA, I think that it's evolved a little bit in my time here, and I just want to say that I appreciate the folks who have been doing this for a very long time, for decades, and not seeing a tremendous amount of change. So as far as SAMHSA, one thing is that we're saying the words now, right? There was a time not too long ago that harm reduction was not something that could be talked about at SAMHSA. So that's a big thing. Another big thing is the things that we're supporting. So for the first time with a NOFO, we recently awarded language from ARPA, the American Rescue Plan Act, allowed federal funds from that act to be spent on syringes, which had not occurred before. And then also Corey already talked about some of the regulation relaxation that's happened since COVID. I think COVID has contributed a little bit to the changes of perception. And then also I think it's important to highlight the face of the overdose crisis has been largely white, and our response to it has vastly differed than it did with the war on drugs that decimated Black and African American communities. So I think that's important to say. All of that being said, SAMHSA is taking an active role, engaging with people who use drugs and people who have operated harm reduction programs for a long time to help guide their work, hiring people with lived experience, and working hard to take something that's very new to us and integrate it across our systems and the things we also support, like prevention, treatment, and recovery. Learning from folks who have done this in the community very well. But there's a long road there here in government because we have to write everything down, right? There is a process for everything. So just working as hard as we can to start that integration process, knowing it's a little bit at a time, as Corey kind of alluded to.
Thanks. And so, Susie, I would ask same question, except for maybe I'll add a twist on what have you seen on campus policies, not just in the state of West Virginia, where I think the work that you've done in a system level has been really interesting, and then probably gives you an opportunity to see how different campuses are all responding differently and modifying their policies. But I know also that you help to moderate a group that meets to talk about this on a regular basis. And so did you want to go ahead and plug that group now, and then maybe share a little bit about what you've anecdotally heard and seen from our colleagues across the country as well?
Yes, thank you, Ahmed. So the Association for Recovery in Higher Education, or ARHE, we have a monthly call at noon. It's, I think, the second Thursday of the month. The next meeting is September 8th, whatever that falls on. So it's that same time every month. And it's an open call that we come together and bring questions, bring concerns, bring challenges to the group to get advice and suggestions and share those resources across the country. And, for us, we've really seen with having the presidential level support for the grant and the activities that fall under the grant, it's great because we have those requirements in the grant activities. And, so we have that built in as, these are things that we have to address and have to accomplish. And, the presidents across the board, and I've trained 5 or 6 of them myself, have been very open, very interested, very engaged in the training and want to learn. They want to know what tools are out there to help their campuses. And, in a lot of cases, because we work with a number of community and technical colleges, being that anchor in the community for setting an example for what happens in the community. So those are a couple of things in our state. We've had, both positive and negative. We had a change in laws last year that increased requirements for syringe service programs. And then this year we had a decriminalization of the fentanyl test strips. And so, you got to take the good with the bad, and you have to make the most of the things that are going well. And, for some of you, you've seen the new one box, because that's one of the things we get the questions about is the training and, the safety of the medication. And we can talk about the Good Samaritan laws and things like that, but the safety of the medication. And so when we frame it as a reduction in risk, sometimes the word harm reduction it's kind of a lightning rod term. So we can frame it in terms of ways to reduce risk for our students and for our campuses. That can also be very important. And having, training requirements relaxed, meaning that we can have lay persons trained to train other people to administer naloxone. That's been very helpful as well. Many of our campuses have medical amnesty policies. And then about a year and a half ago, we did, with our harm reduction group that meets monthly, we put together a pretty lengthy survey to really try to capture things that are happening across the country with regard to, different strategies around harm reduction. And so we had about 37 schools respond to that. And we have some interesting data from that, but we didn't do an IRB and all of that, so it's not published. So that's one of the next steps I would like to take, is to get that IRB and then, launch this into a broader scale so that we know what's happening. Because right now it is that anecdotal. We don't have good, solid baseline data to say, because that's something presidents ask is, what are other schools doing? They across the board almost always ask that question. What are other schools doing? And, so the upside is, if you can get one, then you can use that school as the, thought change leader and leverage that to help other schools follow suit.
Yeah. Thank you. And so, Susie, sticking with you, I wanted to see if you'd share a little bit about how you've seen stakeholder perceptions of harm reduction at various levels, whether it be locally, in your work across the state of West Virginia, on campus, or even nationally change. And what are some of the factors that have contributed to one of two things, either greater acceptance of harm reduction, or in some cases, we see people dig in and it's actually, we've seen increased intolerance of harm reduction across the country. What are some of the things that you've seen?
The more that we normalize it and the more that we have more people out there doing it and reinforcing that narrative that, this specific to naloxone, I'll just stick with that one for right now, because that's been, a large focus for us. And that happened right after COVID started. We had a spike in overdoses, and West Virginia was hit harder than, other places in terms of that increase in overdoses. So really promoting the training, making the naloxone easily accessible, which is, in great thanks to grant funding, being able to mail naloxone to people's homes. So, if they can't make it out to get it, we can mail it. Taking a bystander intervention approach. So we have a whole campaign that has a number of different components that we've developed with our partners at the West Virginia Drug Intervention Institute. And, higher education is very familiar with bystander intervention. And so if we can start with that and speak the language that makes sense and that progress has been made around other topics and, leverage that has been very helpful. Something that started in West Virginia 3 years ago is a Save a Life Day. And a number of our campuses participated in Save a Life Day. And then, we've gotten some press around that. So positive press, frequent positive press is always helpful. So I'm not sure if I answered all the parts of the question that you asked me, Ahmed.
No, that was a great response. I appreciate it. And we'll see. I'm sure that that your fellow panelists would love to contribute as well. And so thank you for that response. And so Chase, coming to you on just your thoughts on how perceptions of those key stakeholders for needed in order to move harm reduction further at the local, state, national campus levels have changed over the years, and what some of the factors are that have helped change them. And again, recognizing that sometimes they're changing in the direction that we hope that they wouldn't be going in as well.
Sure. So my point earlier about the face of this stands, and also I remember a quote I heard at my very first ARHE conference, actually, I believe it was in Reno. And I don't remember who said it, but they were quoting Michael Botticelli, who was at the time the director of the Office of National Drug Control Policy. And the quote was that it's hard to hate up close. And that's always stuck with me, and how important it is for people to be empowered and be in a place where they can tell their story and tell their story to people who are making decisions, eventually be making those decisions. I think what helps is when there's not a table surrounded by people making decisions on behalf of someone, but the people that they're talking about are there at the table helping make those decisions. And that can vastly change perception when folks actually listen. That's been very important. I think it's also important to clear up myths and false dichotomies that are brought up with harm reduction, often unnecessarily pitted against abstinence. There's no reason for this. Abstinence is a part of harm reduction. It is one of the approaches. If that's what folks want, then harm reductionists will help them get there. And then translating it for different audiences. So making sure that we're speaking in the language of the folks that we're talking to, and like jargon, right? So like healthcare providers typically listen to healthcare providers. Cops are going to listen to cops. So it's been helpful to identify champions within those groups that speak harm reduction and can translate that. And then also thinking about harm reduction broadly. I think most people, when they hear it, they immediately think, oh, overdose prevention centers and syringe service programs. And while syringe service programs are incredibly important and save lives, it's not the only thing that harm reduction offers, right? Many health services are co-located there. We've been framing it a lot in terms of harm reduction approaches, which are aligned with many things we already support and do, supporting autonomy, building relationships with people, having very accessible services, lowest barrier, no wrong door. These are all things we support and are very rooted in harm reduction, as well as services like aforementioned, syringe services and naloxone distro programs. And then in terms of entities, right? So thinking about drug user unions and places that are really rooted in the community and community driven. So thinking about the importance of all three and explaining that for folks so they don't just think giving out needles, right? Because while important, we want them to get there, it's so much more than that.
Yeah, thank you so much. And so, Corey, what would you like to contribute to this? The question of, how have stakeholder perceptions changed, and what are some of the factors that have caused them to change?
Yeah, I mean, I don't know that I have a whole lot to add to what Susie and Chase have already said. I actually don't know of sort of longitudinal polling over time. I mean, there was the criminal legal reform and sort of drug policy reform and harm reduction in general are more popular than a lot of people seem to think. There was some recent polling maybe I can find and stick in the chat. People, there is a partisan divide. Democrats tend to be more supportive of things like syringe exchange and naloxone access. But Republican support is much higher than I think most people think. About half of people say they support or Republicans say they support or strongly support things like increased syringe services. And I mean, I do think that part of that is people just having more personal familiarity. I mean, it's an unfortunate reality that as the raw number of people who have died due to overdose increases, the probability that any random person knows somebody, friend, family member, somebody from work, somebody, whatever, somebody on your softball team, like whatever it is, you're more likely to know somebody. And I do think that that has an impact, although I mean, I think that this is really one of the great unanswered questions that we sometimes see big shifts. I mean, for example, we've seen a huge shift in support for same-sex marriage. I mean, just an enormous shift, both in public opinion and in actual action. We saw a similar, just enormous shift in support for cannabis legalization and cannabis access.
Yeah.
And social scientists have some theories about that, but nobody really knows why. And I think that that's it's really great, because if we knew that, like I said, I think that there has been some shifting about people's perception of drug use and whatever you want to call it, substance use disorder, harm reduction generally. But like I said, I think that we haven't had, in my mind, that sort of seismic shift that would say, like a lot of people have said, internally with cannabis, which is kind of like, what are we doing? Like, why do we have this enormous state apparatus oriented towards, arresting and prosecuting and incarcerating people? And I think that that's really the question of how do we get that to happen with other drugs, the way that it has happened with cannabis. I think that what Chase said, this is, like talking to like. I mean, it's definitely the case that I don't go in and generally try to talk to cops. You get a police officer or an ex-police officer to go in and talk to police. And same with physicians and social workers and people who use drugs, right? I mean, whatever it is, you're more likely to respond to and to trust people who are like you. So I think that's part of it. But I guess the answer is I'm not really sure. It definitely seems like things are somewhat moving in the right direction. But it's not totally clear to me that that is inevitable, it's inevitable that we're going to continue moving in the right direction. And I would point to syringe services programs as a place where, I mean, we've seen a big stagnation. I mean, there was a big increase in syringe access 20 years ago. And we have seen some additional states in the last few years that didn't have, syringe exchange programs legalize them. But it's still in that very, to my mind, sort of archaic mindset of, it's still illegal to have syringes generally, but if you live in a place that is close to a syringe exchange program and you have a car and you can get there when they're open from 12 to 4 on Tuesdays, you can get needles. And if you can't, we're still going to send you, just like that, how to get people to, or how to sort of harness the fact that a lot of people really do support these programs, or at least they don't oppose them. There's a small number of, pretty vocal opposition. But the support is actually much broader than I think a lot of people realize. And so it's sort of a question of how to harness that, what people actually think, and kind of ignore the fact that the people who are the loudest oftentimes are not representative,
Yeah, thank you so much. And yeah, difficult question to answer. How do we get that lightning in a bottle, right? And see some of the mass movement towards just increased acceptability like we have with other topics. That's a great point, but I think that we heard a few really good, solid suggestions. First, around intentionality when we're out and we are gathering support for a policy change that we want to make or a new service we want to implement, that when we go to talk to teachers, having teachers be the talkers. When we go to talk to cops, have try to find a police officer who's willing to go with you. Those types of things are great. And I think even one of the most important is the idea of uplifting the voice of the people we hope to serve. And for many of us, it's how are we bringing students to the tables of these conversations, and specifically students who are willing to identify as drug users, who think that it's important for their community. And so I want to transition to some of the audience questions because they've been rolling in and we've got some really good ones. And so, yeah, so I think the one that I want to start with was actually focused to you, Chase, but I think that this is a conversation that we all can contribute and should contribute to. And so firstly, thank you for naming your privilege and how your identity as a white male has helped you to navigate systems that are typically difficult for many BIPOC individuals to navigate, and therefore find and be able to successfully initiate, establish, and sustain their recovery. And so this person is working in expert prevention on their campus, and they wanted to ask, what advice would you and the other panelists as well give for a new professional trying to integrate diversity, equity, and inclusion into prevention, intervention, and harm reduction services, given the history of this work with the BIPOC community?
That's a great question. I really appreciate it. And the first thing is to engage people of color and talk with them, not try and rescue. And then also something I see that is important in my work with organizations, not treating equity as an afterthought, but something that is intentional and central to what we're doing. And in fact, especially with this, more than anything, drugs and drug policy is inextricably tied with racism from the very beginning of interdiction in the early 20th century, 1900s. So making it central to the conversation and not an afterthought, engaging in communities, not doing for people, supporting work that they're likely already doing within their own community. And then I'm going to put a resource in the chat. At SAMHSA, we have an Office of Behavioral Health Equity. I don't know that I can send it to, can I send it to everyone? I'm putting it in the panelists and hosts, and hopefully it can get out there. But the Office of Behavioral Health Equity is led by a colleague and a personal friend of mine, and they are doing a lot of very strong work to shift systems in SAMHSA in the way we think and act about this, and an invaluable resource. So there's a lot of publications out there and stuff that's, I think, helpful.
And Corey or Susie, anything that y'all would like to add about the idea of how diversity, equity, and inclusion can be infused into the continuum of care on a campus when it comes to alcohol and other drugs?
Well, I agree with Chase in terms of, asking what various communities need and want, and, how can what you have to offer support what they would want to see happen?
Absolutely. Yeah, so similar to what we said earlier is how are you hearing your students, and what spaces are you creating for your students to be able to provide the feedback and let you know what it is that they need and what it is that they're seeing amongst their peers as well. Yeah, that's great. I think too that conversation, that it's a long time that that we've needed to have conversations around how are we teaching health literacy to students, especially the students with lower socioeconomic status, first generation students and students of color, and how are we talking about, how are we demystifying this idea that 6 months ago when they were high school seniors and considered children, and now they are adults who should know how healthcare works, should know what a copay is, should know how to access services, should know all of these things, and what role do we have as health educators to be helping them to understand these concepts so that they can advocate for their own needs to be met, is a conversation that we need to be having in higher education. And so the next question I will open to anyone. And so the question is, the person who asked the question states that through working with several campuses and fraternal organizations, one barrier towards implementing harm reduction that remains are concerns around liability. And so administrators and leaders have been perceiving harm reduction efforts as a liability risk. And do any of you have any advice or suggestions on how to address this concern in an effort to receive buy-in and support for these efforts?
Well, this sounds like a me question. I would say I totally agree with what Chase just said in the chat. Yeah, I'm always happy to talk to folks, right? I mean, and you know, there's sort of a threshold question here, which is whether this is really just an excuse. Because if it really turns out that the administrators or whoever it is just doesn't really want to do it, and they're looking around for an excuse, and they think that this is a good one, that can be a different conversation, and can be sometimes can and should be addressed either differently or in tandem with the actually your liability risk is pretty low question. So I think that's to keep in mind. But if it is a legitimate concern, I mean, I'm happy to talk to folks. The general answer is, I mean, it kind of depends on what you're doing, but a number of states have passed laws that provide additional civil liability protections for people who are giving out naloxone, for example. In some cases, those extend to things like giving out fentanyl test strips. There was really just no real reason to believe that doing that would increase your liability risk. That's just not how that law works. And we have like an academic article that talks about how prescribing naloxone doesn't increase liability risk, and the general idea there extends to all kinds of other things. So I don't know. I think the answer is, I mean, I'm always happy to talk to people. You can just reach out to me, and I'm happy to talk to the council for the university, and we've done this. And I don't know. I mean, I think this is also a place where talking to peers can be really helpful. Not nobody, but it's rare that an organization like a university wants to be the first to do something, and sometimes they don't want to be the second. But if you can, sometimes they're happy to be the third. And talking to the first and the second can really help ease people's, ease people's minds. So to me, I think it kind of goes back to ideas like, from a straight legal perspective, it's most attorneys for universities do kind of get relatively quickly that this probably isn't increasing their liability risk. And to the extent that if they think that it might be by a tiny, tiny bit, everything you do, you have a campus fun day, you have like a bouncy house, or you have a water balloon fight or something like that, that's increasing your liability risk too. But you put in a water fountain, that's increasing your liability risk, at least potentially. But somebody's made the calculation, well, like, this is worth it, right? You're probably much more likely to get sued if you have, a student group having a water balloon fight on the quad than you are from, letting a group give out naloxone or giving out naloxone yourselves. And at some point, if you can't be convinced that your risk is zero or extremely low in absolute terms, which it is, there is this question of weighing, I mean, it's like the ship in port, right? The safest place for a ship is in port, but that's not what ships are for. It's the same with everything, right? Everything you do has some calculation, and on the weighing on the other end is you might save a student's life, so that should weigh pretty strongly in your calculation. And but yeah, I mean, I think just having a conversation is a good way to do that. And I'm happy to support folks who need help with talking points. I'm also happy to have those conversations with counsel, and I've done that on a couple of occasions. And I would say sometimes I'm thinking of two particular instances. One time it worked, and the other time it became clear from having that conversation that it wasn't actually a legal concern. That the administrator who had to sign off on it just didn't want to do it, and they were hiding behind their attorney, and it didn't really matter what the actual law, was. So that's why I brought that up. But I don't know.
So I'm glad Corey answered that question, because I had a question for him similar to that. When we do hit barriers, we go back to, we have fire extinguishers. We don't anticipate there being a fire, but we have a fire extinguisher, the AEDs. And, for me, my question for you is that, if we have AEDs that shoot electricity through people's hearts, to me, that is a whole lot more dangerous than naloxone. And so how are we able to use that, not in an obnoxious way, but, that is an example and kind of a contradiction of, this heart attack patient is, life is more valuable than this person that, it may be an overdose, might not be. And then, data wise, how many times do we have heart attacks of college students? Probably not nearly as many as we have suspected or confirmed drug overdoses. And, when we have something that is a life-saving medication with very, very low risk, how do you turn that around to help them understand that it's actually a greater liability to not have it? And then, knowing your state laws in terms of the Good Samaritan laws, because that's something we depend on quite a bit. And we put together a standard operating procedure and all of that with our Nalox box initiative, which is, now transitioning with the one box instead of the Nalox box.
Yeah, thank you all. And so I think we have time for probably one more audience question. And we have a lot. And so I want to say that thank you to everyone who submitted a question. And if we weren't able to get to yours, that I do apologize. But I think that there are two questions that I can maybe group in as one. And so one of the questions talks about as a preventionist or a prevention practitioner, they struggle with the idea of drug testing strips and naloxone being a form of prevention. And would it be acceptable to complement those resources with education and things like social norming as well? And then which is I think is a great question. But and then we have another that person who talks about how on their campus alcohol is still the primary concern among students, and that what they feel is happening is that things that are happening, the concerns that are very real in other areas of the country are ending up on their campus, and it's kind of diverting from the reality of what they're seeing, which is students drinking too much and being transported to hospitals. And so the question is, what advice would y'all have to help them keep the harm reduction initiatives and support focused on what is specific to their campus, rather than maybe what some of the national talking points are? And so I guess the two questions I see are this kind of struggle to see harm reduction and the state that we should be moving towards as a country, and the prevention work that has been happening on college campuses, and how are the two supposed to coexist and maybe work with each other or complement each other, if that makes sense.
That makes a lot of sense, and that's a great question. So being in harm reduction here at SAMHSA, we were placed in the Center for Substance Abuse Prevention. So I work alongside a lot of preventionists, primary preventionists, targeted prevention, tertiary prevention. And it goes back to my earlier point about kind of dispelling myths and false dichotomies here. It seems like a communication problem, because these things do not have to be at odds with one another. We can support both harm reduction and prevention. It is possible. And as far as community specific things, I think that's the challenge for us at the federal government, is being responsive to every single community in the United States. And one block is different from the next in a lot of ways, right? So how can we be responsive to the individualized needs? And that's why we put out support for all of these things. And we want to support all of these things and seek ways that they integrate and go together. I think harm reduction is very much overlapped and aligned with prevention. And the fact we have primary prevention, and is important, education is important, empowering people with knowledge, that's a central tenet of harm reduction as well as with recovery and prevention, building healthy communities and taking care of social determinants of health, taking care of people. These are all protective factors for both people who have not used drugs yet and for people who have used drugs. Additionally, there is a large amount of people that prevention can help. We don't give up on people after the first time they use drugs or take a drink, right? We still have services for them. To the alcohol point, this has been done well at college campuses with alcohol and can be extended to other things. Prevention information saved my life a number of times as a harm reduction intervention. And also just this, I like this point. So thinking about treatment, recovery, and prevention, harm reduction, how they work together. And there's a very famous statistic from the NISDA, the National Survey of Drug Use, and that's that 1 in 10 people with a substance use disorder will receive treatment this year. It's about that every single year, that 90% of folks with a substance use disorder will not receive treatment. What's not often said is that 97.5% of that group, the 90%, did not feel they needed treatment. And that's not an indictment of those people. That's an indictment of the options we have available to folks with a substance use disorder. So there is a lot of room for prevention, harm reduction, treatment, and recovery to come together and widen this catch net so that we're catching people and taking care of people. Because I imagine those folks would like to make some positive change in their life, and it's maybe not what we have to offer them. So the short answer is we can support both. Don't want to take away from one for another, and find ways to align and seek the common ground that we both share, which is a lot.
Yeah, that's great.
Yeah, so I actually until last semester taught on a college campus, but I don't have direct experience with providing these kinds of services on a college campus. So I would also really like to hear groups that have really done a good job of integrating these. But I endorse almost everything that Chase said. I mean, there is not a dichotomy here, right? I mean, this is another one of those bizarre things that sometimes hear. They're like, oh, harm reduction is so against prevention or something like that. I mean, I know a lot of harm reductionists, and it's like nobody is opposed to prevention. I mean, that's just it's ridiculous. I mean, harm reduction is a part of preventing acute bad events, right? But it's not that I mean, it's just part of. I mean, I view it, and I think almost everybody who's doing harm reduction work just views them as like different places on the continuum, right? The idea is to empower people to live their best lives, to live healthier lives, to have, the best, life that they can have. I think sometimes you run into bits at like the far spectrum, right? Where you have people, you have people who say like, well, you need total abstinence, and obviously harm reductionists generally don't agree with that. But, outside of that, like there is no you know, the ideas are not in opposition. So I think it makes perfect sense, both. I mean, and I would say, I mean, I obviously fully support college campuses doing things like providing harm reduction supplies. But I do think it's important to note that, like, that's not what harm reduction is. Like giving somebody some naloxone, you know, like there's much more. Like harm reduction is providing education. It is, you know, making sure that people have access to, you know, care, to professionals, whether they be, you know, like I think you made a great point, Ahmed, that, you know, it's not just necessarily substance use disorder mental health professionals, but also like I might need help with food, like I might need help with housing, you know, like you know, there are a lot of things, you know, I mean, you know, whatever, maybe this is something that not all mental health professionals say, but, you know, for some people, misusing drugs is a very rational response to like a world that is like really hard. And there are a lot of things that campuses can and should be doing to improve the lives of students and their families. And that's prevention as well. So it's up there, but it's a really great question.
Yeah, thank you. And so I asked somebody who on Ohio State's campus am working in prevention and working in with our students in recovery and leading some of the efforts around naloxone and harm reduction on campus. When I'm having these conversations with students, staff, and faculty, for me, it's important to emphasize this idea that maybe we need to stop thinking about harm reduction as a set of services which are different from other services we offer on the continuum, and instead realize that it's an approach to the work. That when I'm a practicer of harm reduction, if I believe in meeting people where they're at, if I believe in people having autonomy over the direction of their lives, and if I believe in not just witnessing and recognizing the humanity in each individual that I meet, no matter what decisions they make about drugs and alcohol, but simply because they're a human being and they deserve access to the resources they need to have a good life. If I can embody that in my work, then I'm doing harm reduction. Right. And a lot of the efforts to try to stop overdose deaths and to make sure that people stay healthy are just common sense after we start thinking about it from that framework. And so for me, it's about talking about harm reduction is not a group of services, but a mentality. And if we can embrace this mentality as a campus, our students are going to be better off for it. And so I want to so we're almost out of time here, and so I want you all to leave our audience with a few parting thoughts. And so I wanted to see if briefly you all could share around this idea that oftentimes it feels like an uphill climb to get universities and administrators to be agreeable to harm reduction efforts on campus. And so if you all could add just one small thing that each of us can do when we leave and we go back to our campus tomorrow to begin moving that rock up that hill, if that makes sense. I'll start with you, Susie.
I think to bring examples and to bring solutions, do your research and bring that information so that you have answers to the questions, or you have resources that you can get those answers to the questions that administrators might have. And, try to think about it from their perspective. And, if you can enlist, if you have a law school, or if you can enlist assistance of an attorney, and maybe that's something that Corey is a resource for, to help anticipate, what are going to be the barriers, what are going to be the challenges, and, to assume that, the best, that, the liability question really is concern about the liability, and not, another agenda, and, see what you can bring as a solution to the problem.
Thank you. Chase?
First, since we're closing, I just want to say thank you to you, Ahmed, and the organizers of this and the brilliant people in this panel and audience. It's very enjoyable. I think practically speaking, what I would say is build relationships and identify the champions. in the space that you want to change, and focus on the relationship first, not whatever thing is going to be foreign and scary to them at first. But really, I think like the most important thing you could do between today and tomorrow is do something kind for yourself and reach out to people who love and care about you. I think that folks in this field forget to do that very often, myself included.
Thank you for that, Chase. And Corey, last but not least, Corey.
No, I have nothing else to add. I agree completely with everything Susie and Chase just said.
Yeah. Okay, guys. So be the person with ideas about solutions and look for your champions, guys. And if you can start doing that, I promise you'll be headed in the right direction. And so I want to take a minute to thank each of you for being here, for providing your wisdom, your time, but most importantly for allowing us to see how important this work is to you and this avocation that each of you are living in, trying to create a more just world for drug users. And so thank you for being here today, and I will now turn it back over to my good friend Anthony.
But I just echo everything that Ahmed shared, and just thank you to our panelists for sharing of themselves and of their work. I do just have a couple of updates that we have. We do have a couple of upcoming events. We have a water cooler chat happening on September 13th, as well as a webinar at the end of September titled Finding Common Ground, the Intersection of Student Development Theory and the Recovery Support. I did just want to remind everybody that today's session has been recorded and can be expected to be uploaded to our website within 3 business days. Thank you, everybody, and I hope you have a great rest of your day.